Good day to everybody joining us, and welcome to today's X-Talks webinar. Today's talk is entitled Each Hour Counts, Improving Management of CREs and Other Antibiotic-Resistant BSIs with Rapid Molecular Diagnostics. My name is Rebecca, and I will be your X-Talks host for today. Please note that live audience members can apply to receive a Professional Acknowledgement for Continuing Education, or PACE credit, which is issued by the American Society for Clinical Laboratory Science. More information will be available through today's exit surveys, which will appear following this webinar. Today's webinar will run for approximately 60 minutes, and this presentation includes a brief Q&A session with all of our speakers. This webinar is designed to be interactive, so please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box. This chat box is located in the control panel on the right-hand side of your screen. If you require any assistance at all, please contact me at any time by sending a message using this chat panel. At this time, all participants are in a listen-only mode, and the presentation slides will advance automatically for you today. Please note that this event will be recorded and made available for future download. At this point, I'd like to thank Nanosphere for helping develop today's content. Nanosphere is enhancing medicine through targeted molecular diagnostics that result in earlier disease detection, optimal patient treatment, and improved healthcare outcomes. The company's versatile technology platform, the Verigene system, enables clinicians to rapidly detect the most complex, costly, and deadly infectious diseases through a low-cost and simple-to-use multiplexed diagnostic test. A growing portfolio of FDA-cleared tests for infections of the bloodstream, respiratory tract, and gastrointestinal tract enables the delivery of rapid, accurate, and clinically relevant diagnostic results that enable earlier detection and optimal treatment of patients with infectious diseases. For more information, visit www.nanosphere.us. I'd now like to introduce our speakers for today's event. Unfortunately, due to unforeseen circumstances, Dr. Ledebauer will not be able to speak in the webinar today. He has expressed his apologies, but has found a very capable replacement. With that said, the speakers that will be joining us today are Dr. Karen Carroll, who is a professor of pathology and medicine at Johns Hopkins University School of Medicine. Dr. Carroll joined the faculty at Johns Hopkins in 2002 as the director of the Division of Medical Microbiology and of the Fellowship Training Program in Medical Microbiology. She was promoted to Professor of Pathology in 2006, and Dr. Carroll's focused areas of clinical research at Johns Hopkins have been in the areas of epidemiology and diagnosis of healthcare-associated infections, especially those concerning Clostridium difficile infections. She is a fellow of the American Academy of Microbiology, the Infectious Diseases Society of America, and the College of American Pathologists. Dr. Carroll has authored over 175 peer-reviewed scientific papers. Dr. Carroll attended the College of Notre Dame of Maryland for her undergraduate work in biology and at the University of Maryland School of Medicine for her medical doctorate. She also completed a clinical fellowship in infectious diseases at the University of Massachusetts School Medical Center and a clinical fellowship in medical microbiology at the University of Utah School of Medicine. Also joining Dr. Carroll today is Dr. Blake Buchan, who is an assistant professor of pathology at the Medical College of Wisconsin. He also serves as assistant director of clinical microbiology at Dynacare Laboratories. Dr. Buchan received his PhD in microbiology from the University of Iowa in 2009. Following graduation, Dr. Buchan completed a 2-year postdoctoral training term at the Medical College of Wisconsin and has since continued his professional career at MCW. He was recently promoted to assistant professor of pathology. Dr. Buchan has also currently serves as the associate director of clinical microbiology at Dynacare Laboratory, which is located in Milwaukee. Dr. Buchan's interests include MALDI-TOF, MS, PCR, and microarray-based Diagnostics for the detection of bacterial, viral, and fungal pathogens, including methodologies for detection of these etiologies directly from clinical specimens. He has served as study coordinator and principal investigator for numerous clinical trials evaluating novel diagnostic assays and has a strong record of publication in peer-reviewed journals. Also joining the panel is Dr. Deborah Goff, who is Clinical Associate Professor at the Ohio State University College of Pharmacy. She is an infectious diseases specialist, also at the Ohio State Medical Center. Dr. Goff joined the Ohio State University Medical Center in 1989 as an infectious diseases specialist. She is the director of the Infectious Diseases Residency Program, and she is also a member of the Antimicrobial Stewardship Program, also known as ASP. She is an associate professor at the College of Pharmacy, and Dr. Goff received her Bachelor of Pharmacy degree and Doctor of Pharmacy degree and performed her pharmacy residency at the University of Illinois in Chicago. As part of ASP, she is actively involved in developing strategies to control the escalating rate of antimicrobial resistance. The team manages both community-acquired and healthcare-associated infections. Most recently, she developed a medical app called STABIT, which is short for Staph aureus, bacteremia is terrible, to help educate clinicians at OSUMC on the management of patients with Staph aureus bacteremia by using the iPad. Her research interests includes antimicrobial resistance, clinical outcomes research, antifungals, and innovative ways to educate using technology. And now, without further ado, I'd like to hand this webinar over to our first speaker today, Dr. Carroll, who may begin when ready.
Well, thank you, Rebecca, for that introduction. What I plan to do for the next 15 minutes or so is discuss the problem of bloodstream infections, including the issue of the rising incidence of gram-negative and other resistance among cases of bacteremia. The bloodstream infections rank among the most serious clinical problems worldwide. In the United States alone, we see approximately 750,000 cases of bloodstream infections per year, with about 250,000 of those being acquired in the healthcare environment. Bloodstream infections account for 20% of hospital-acquired infections in ICU patients. More importantly for the patients, bloodstream infections remain a leading cause of mortality. And what I've shown here is the attributable mortality associated with both a community-acquired and hospital-acquired bloodstream infection. What I mean by attributable mortality is mortality that is directly a consequence of that bloodstream infection. You can see that both in terms of community-acquired infections as well as hospital-acquired infections. If the patient is sick enough to require ICU admission, the attributable mortality can be quite high, ranging anywhere from 40% mortality to up to 55% for hospital-acquired infections. Another important observation is that mortality is higher with drug-resistant organisms. As Dr. Cosgrove showed in her elegant paper in the Clinical Infectious Disease in 2003, patients who have bacteremia caused by methicillin-resistant Staphylococcus aureus have a higher risk of dying than those patients who have methicillin-susceptible Staph aureus infections. Likewise, in the paper by Diaz-Granados, patients who have vancomycin-resistant Enterococcus have almost a 3-time higher rate of dying than patients who have vancomycin-susceptible enterococcal infections. And finally, in this era of emerging gram-negative resistance, as the investigators in the Schwaber paper have shown, patients who have gram-negative rod infections caused by extended spectrum Betalactamase producing organisms have a much, much higher rate of dying than patients who have susceptible gram-negative infections. So all of this means that the cost of bacteremia can be quite substantial. Managing sepsis and its complications costs approximately $16.7 billion per year in the USA alone. Patients with antimicrobial-resistant bloodstream infections incur more hospital charges compared to patients with susceptible organisms. And you can see the costs that I have listed here. For community-acquired bloodstream infections, it's about $43,000 in additional costs. And for healthcare-associated bloodstream infections, that value is lower at $27,000 in additional costs. Now, you might say, well, that seems a little paradoxical given the fact that patients with healthcare-associated infections tend to be sicker, and that is true. And the problem is that those patients have a higher rate of mortality, so the hospital costs are actually less, unfortunately. So this next slide includes a table that I've derived from the two references that you see at the bottom of the slide. And I wanted to review the microorganisms causing bloodstream infections because I think this is important with respect to the types of assays that we might want to bring into our laboratories with respect to rapid diagnostics. So that you can see in the community setting that approximately 54% of all bloodstream infections are caused by gram-positive organisms, with Streptococcus pneumoniae and Staphylococcus aureus being the two most prevalent species. Approximately 44 to 47% of infections are caused by gram-negative organisms, with E. coli and Klebsiella species topping the list. In community-acquired bloodstream infections, Candida species are not very common, and polymicrobial episodes, that is, 2 or more organisms, account for approximately 4 to 7% of all bloodstream infections. Now, when we look at nosocomial infections, that is, infections acquired in the hospital, we see that the rate of gram-positive organisms actually increases to somewhere between 60% to 75%. And this is due in large part to gram-positive organisms that cause most of our central line-associated bloodstream infections. And in this case, coagulase-negative staphylococci and Staphylococcus aureus, in particular methicillin-resistant Staphylococcus aureus, top the list, followed by Enterococcus. You can also see that for the 25 to 40% of the gram-negative organisms, that in addition to the E. coli and Klebsiella species that we mentioned for community-acquired infections, Pseudomonas and Antibiotic-Resistant species now become important. 9% of nosocomial bloodstream infections are caused by Candida species, and approximately 12% are polymicrobial episodes. And I can say at Johns Hopkins, we see about 10 to 12% polymicrobial infections, and I think that's an increase now compared to several years ago. Now, if you are in the intensive care unit, the list of gram-positive organisms are similar to what I described for nosocomial infections, but in terms of gram-negative organisms, we now see that Serratia marcescens and Acinetobacter also become important. And then the Candida species increase depending upon the type of ICU. In one study, the polymicrobial episodes could approach as much as 21%. That seems a little high to me. In our environment, it's somewhere around the 10% that I described for nosocomial infections in general. So one of the things that we actually have to be on the alert for now is emerging resistance mechanisms in the gram-negative causes of bloodstream infections. There are a variety of resistance determinants that are seen among these gram-negative rods, and the type of resistance depends by varies by hospital type, by geographic location, and by whether the patient acquired the infection in the community versus the hospital. And we see tremendous variation in the United States, with the Northeast, for example, having more Carbapenemase producing KPC-type mechanisms of resistance, whereas the rest of the country these rates tend to be a little bit lower. The most common resistance mechanism that we see in the United States are extended spectrum beta-lactamase producing organisms, and these are primarily in the molecular class A category. These are generally plasmid mediated, with the TEM type enzymes being the most common, although the SHIV type enzymes are also described. And I would say over the past 5 years, we've also seen a recent increase in the CTXM clones in the United States. And here at Hopkins, we know that we are seeing a significant number of CTXM organisms among our ESBL producers. Thirdly, we have the chromosomal AMP-Cs. I think it's very difficult for clinical laboratories to know how much of the chromosomal AMP-Cs they're actually seeing in their environment because we really don't have a good phenotypic test for detecting these. This mechanism can either be plasmid encoded or it can occur as the result of upregulation of the natural occurring chromosomal AMP-Cs due to a promoter or attenuator mutation. And I refer you to the review that I have listed at the bottom of the slide for additional information about these mechanisms. This slide is a summary of just some, I emphasize some, of the mechanisms of carbapenem resistance. We can see that throughout the world, we have the class B hydrolyzing enzymes. These tend to be the metallo-beta-lactamase producing organisms. These are not so common in the U.S. However, that said, many of us are concerned about the emergence of the NDMs or the New Delhi metallo-beta-lactamases. And these have begun to appear sporadically in the United States to the point that the Centers for Disease Control would like hospitals to start monitoring what they're actually seeing and maybe even surveying for these different resistance mechanisms. Most of the class B hydrolyzing enzymes are found among Pseudomonas aeruginosa, Acinetobacter species, and the Enterobacteriaceae. We also see class A hydrolyzing enzymes. I've listed some of them here, the most important one of which for us in the U.S. are the KPCs, or Klebsiella pneumoniae, Carbapenemase enzymes. These are more prevalent in Klebsiella pneumoniae and E. coli, although in our environment here at Hopkins, we've also seen these among Klebsiella oxytocca strains as well as Enterobacters. And then finally, the class D enzymes. Examples of these are the OXA24/40 enzymes and OXA48. These are more prevalent in Acinetobacter species and Pseudomonas aeruginosa. Now, regardless of the type of enzyme or the organisms involved, these mechanisms render the isolates completely resistant to all of the beta-lactams. This includes penicillins, cephalosporins, cephamycins, and carbapenems. The one exception could be the monobactams with respect to the metallo-beta-lactamase producing strains, but in many cases the organisms are also resistant to aztreonam through other resistance mechanisms. Because these are encoded on highly transmissible plasmids, oftentimes in addition to be resistant to all of the beta-lactam antibiotics, these organisms are also resistant to the aminoglycosides and the fluoroquinolones, rendering them almost impossible to treat with any agent with the possible exception of colistin or polymyxin B. So there are other mechanisms of resistance that are not related to plasmid-encoded enzymes. These include altered porin channels, an increase in efflux mechanisms, and then altered penicillin binding proteins. And I've already mentioned the AMP-C production on the prior slide. So with this as background, I think it's clear that if we had rapid diagnostics, that we could potentially impact patient care. We know that each hour that appropriate antimicrobial treatment is delayed a sepsis patient's mortality rate increases by 7.6%. We also know that rapid blood culture testing has been shown to reduce hospitalization costs, and a very elegant paper by Bauer et al. In Clinical Infectious Disease that looked at implementing rapid results reporting for Staph aureus blood cultures, including MEK-A detection, demonstrated an average 6.2-day reduction in length of stay and a $21,387 reduction in cost per Staph aureus infected patient. So this is just one particular organism, and that these data are quite encouraging for newer technologies that actually test for a broader range of pathogens. We also know from studies by Graham Forrest with DNA fish technology, for example, and other studies that are mentioned here on this slide, that when combined with antimicrobial stewardship interventions, rapid MEK-A reporting for patients with Staph aureus bacteremia results in a 25.4-hour reduction in the time to optimal antimicrobial therapy. We also know that this could reduce the impact of contaminants. Patients with false positive blood culture results triggered by contaminants have hospitalization costs that approach $9,000 higher than true negative blood culture patients. And that in the study by Wang, as well as in other studies, as I said previously, performed by Dr. Forrest with DNA fish technology, that rapid molecular detection of coag-negative staph can reduce length of stay by as much as 5 days, lead to antibiotic discontinuation 32 hours sooner, and then overall decrease infection-related costs. So at this point, I would like to now hand over the presentation to Dr. Deborah Goff to discuss the challenge clinicians face managing patients with antibiotic-resistant bloodstream infections.
Thank you, Dr. Carroll. Well, I would like to discuss the antibiotic dilemma. As a clinical pharmacist, let me go forward and try to decide the most effective empiric antibiotic therapy. What is the most effective? Well, I can tell you what the most common regimen is: piptoracillin, tazobactam plus vancomycin with or without a second gram-negative agent is pretty uniform across the United States as the most common empiric antibiotic regimen. But the key is, what are the
Dr. Goff, I'm so sorry to interrupt. It appears that we can't see your slides at the moment. Could I just ask you to retry sharing your screen at this point?
I'm sorry, do what?
Share your PowerPoint or your desktop screen with us. It looks like we can't see the slides that you've prepared.
Okay, well.
There you go. So sorry to interrupt.
That's okay. So we're on the slide, what is the most effective empiric therapy? So the key is, what are the organisms that we need to be covered? You can't decide the most effective therapy until you know that. And we really count on our microbiology lab as part of our stewardship program to provide not only a hospital-wide antibiogram, but unit-specific and combination antibiograms. What this does is it allows the stewardship pharmacist to really recommend then the most effective antibiotic based on our own local susceptibility data. So what are the organisms of most concern? The multi-drug resistant organisms by the IDSA guidelines, the escape pathogens, Enterococcus, Staphylococcus, Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter. And today we're focusing on really a discussion of the gram-negative organisms. Okay, so the challenge now is I can't advance my slides, so I'm not sure. Well, there we go. All right, so some of the concerns, I know with healthcare reform, economic concerns are really front and center in our stewardship program. You look at Dr. Falagas from Greece, who did this meta-analysis of the Carbapenem-resistant non-fermenters, attributable mean hospital charges ranging from $58,000 to $85,000. Our own study done here at Ohio State, led by Dr. Carrie Bauer, one of our ID pharmacists, looked at comparing extended infusion cefepime to standard 30-minute infusion, and we showed a significant reduction in mortality, 20% versus 3%. Our hospital costs were $23,000 less per patient, favoring our extended infusion group. So if you treat with the right drug, at the right dose, right infusion time, not only can you make a difference in patient outcome, you can also impact cost by decreasing length of stay. Others have looked at stewardship's impact along with outcomes and mortality in the ICU. And you look at inadequate antimicrobial therapy 61% of the time, and it contributes to the significant mortality. So really the clinical pearl from this study in CHEST is time to effective therapy is critical if we want to make a difference in clinical outcomes. So when we look at first-line therapy, for the gram-negatives, there's really 3 to select from. It's either piperacillin and tazobactam, cefepime, the anti-pseudomonal carbapenems, which will be useful in the hospitals with high ESBLs. But multi-drug resistance has really created a challenge trying to determine which of those would be most effective. Based on your own local susceptibilities, you may need to add a second agent, the aminoglycosides, which is not real pleasant when you have to add vancomycin to cover gram-positives. The two together usually provide increased nephrotoxicity. The fluoroquinolones have really become very limited in their usefulness due to profound resistance, which leads us then to colistin, which is an agent from the 1960s that unfortunately way too many of us have experience with now and reserved for the treatment of multi-drug resistant Pseudomonas or Acinetobacter or the CRE organisms with KPCs and NDMs, which we have not yet seen here at our institution than NDM, but unfortunately we have seen KPCs. So we gain more experience with this. Let me now turn it over to Dr. Buchan, who's going to discuss the role of rapid testing. Dr. Buchan?
Okay, thank you, Dr. Goff, for the introduction, and thanks everyone for joining us today. So in the next few slides, I'll be talking about one of the solutions for rapid testing of positive blood cultures, really with the focus of gram-negative organisms. So when you think about blood cultures and the traditional workflow, of course it all begins with the patient and drawing optimally 3 sets of blood cultures. These are then typically incubated in an automated blood culture instrument, and the majority of organisms will flag positive within 24 to 72 hours. At that point, a simple gram stain can be conducted to confirm the positive results. And this gram stain gives limited but important information. It can tell you if you're dealing with a gram-negative organism, a gram-positive organism, and if it's a gram-positive organism, based on the morphology, you can decipher whether you're likely looking at something of a Staphylococcus lineage or Streptococcus lineage. But that's really all the information that you can provide for this critical value upon blood culture positivity. Following positivity, then really you need to do a subculture of that positive bottle to obtain organism so that you can further identify it. Once that organism grows, which is typically an 18 to 24-hour incubation, you can begin to do some of the biochemical tests to get an identification. These biochemical tests can range from simple rapid spot tests all the way through automated identification using fully automated identification and susceptibility testing systems. These tests, again, can range from rapid tests giving some results within 2 hours out to 24 hours for essentially overnight tests. Now, depending on if you work in your susceptibility testing following some of your rapid spot tests or whether you incorporate that as part of a broader identification and susceptibility panel, it really takes typically 48 to 72 hours from initial culture positivity before you're able to report out an identification and susceptibility for the organism in that bottle. And that's a long window of time for patients to be on empiric therapy, which may or may not adequately cover the organism present. So when we think about gram-negative organisms, really Betalactamase is the first thing that comes to mind as far as resistance determinants. Many of these, as Dr. Carroll had introduced, have chromosomal origins. However, they can also exist on plasmids or as part of transposable elements such as transposons. If part of a transposon, They can certainly hop from the chromosome to a plasmid or back from a plasmid to a chromosome, and these will also enable dispersion between closely related organisms, especially within the Enterobacteriaceae family. Again, with the 4 classes of beta-lactamases we're aware of, A through D, class A enzymes are probably the most prevalent, and within the class A, we have the 10 beta-lactamases, which are found in Enterobacteriaceae, non-fermenters such as Pseudomonas, Haemophilus, and Neisseria species. These enzymes typically are thought of as more narrow-spectrum enzymes having activity against maybe ampicillin, penicillin, and first-generation cephalosporins. However, these are really the parents of the extended-spectrum beta-lactamases. And the way these enzymes transition from a narrow spectrum to a broad spectrum is through minor point mutations in the beta-lactam binding pocket of these enzymes. And this is just an example. Now, with the 10 enzymes, for example, you've got probably over 200 varieties of these enzymes. However, if you look at just some key amino acid positions within these enzymes, and you look at the amino acid substitutions, minor substitutions can have a dramatic effect on the MIC of these organisms to septazidine. For example, a single base pair or a single amino acid substitution at position 164 can transition from an MIC of 0.12, which is quite susceptible, to 16, and 2 amino acid substitutions can drive that susceptibility, or that MIC, to septazidine up to a very resistant state of greater than 256. Because of these minor amino acid substitutions and point mutations, it's very difficult to identify and characterize these adequately using molecular techniques. But they are very significant, and a study back from 96 and 97 demonstrated that at that point, approximately 20% of Klebsiella isolated from bloodstream infections contained ESBLs. So in addition to being difficult to pick these out and characterize these using molecular techniques, our in vitro testing algorithms also fall a bit short. In this case, with 9 patients that were treated with a cephalosporin that tested in vitro as susceptible or intermediate, 3 patients died and 5 required a change in antimicrobial therapy. In this study, overall, there were 32 patients that were treated with cephalosporins that tested in vitro as susceptible or intermediate, and 4 of 4 that were reported out as intermediate failed therapy, and 15 of 28 reported as susceptible failed therapy. So this highlights the fact that Enterobacteriaceae and other bacteria carrying these ESBLs are, again, very difficult to peg using both in vitro susceptibility testing as well as molecular techniques. Now, some of the things that COSI has done to reduce the breakpoints for these have begun to address this problem. Really something that's emerging, I think, across the country and in many institutions are the Carbapenem-resistant Enterobacteriaceae. We see a number of these here, primarily KTCs, but the means to carbapenem resistance, really there's 3 general mechanisms. The first 2 really are hybrids of combining an upregulated class C enzyme, like an AMP-C, which will give you modest carbapenemase activity. But when coupled with an outer membrane porin alteration or upregulation of an efflux pump, this can result in high-level resistance to carbapenems. Now, in contrast to the ESBLs, carbapenemases are much more conserved in sequence, and they have a much more predictable substrate specificity. That is, carbapenemases are typically going to be very extended spectrum beta-lactamases, hydrolyzing 1st through 4th generation cephalosporins, cephamycins, carbapenems, and in many cases as trienam. Many of these enzymes are located on plasmids, and because of that, as Dr. Carroll had mentioned, they're oftentimes carried with resistance mechanisms to other classes of antibiotics. So looking at carbapenem-resistant Enterobacteriaceae, typically they're also associated with increased and multi-drug resistant GNRs, gram-negative rods. So when you look at treatment options for these very resistant organisms, you are quite limited. 2 drugs that you typically think of would be something like tigecycline or colistin or the polymyxins. So with tigecycline, at least initially, many of these multi-resistant gram-negative organisms will test as susceptible. However, we know that within 3 to 4 weeks of treatment, if used in monotherapy, the resistance to the tigecycline will begin to emerge. In contrast, colistin will have much slower emergence of resistance. However, it has a fairly negative side effect profile for the patients. So how do we screen for these carbapenemases, including KPC and NDM? And again, this is very important to identify these not only from a patient management standpoint, because of the association with multi-drug resistance, but also from an infection control standpoint, in that we don't want these spread throughout our healthcare institutions. So when we think about screening, screening for carbapenemase resistance in Enterobacteriaceae, ertapenem is going to be the screening drug of choice because it typically has the highest sensitivity. When you look at non-fermenters, imipenem would be the carbapenem of choice for screening. So any organism that tests as intermediate or resistant using these screens really needs to be confirmed using one of two methods. This could include either the modified Hodge test or a molecular method to identify the gene responsible for these carbapenemases, again including KPC, NDM, VIM, IMP, or a number of the other carbapenemases. Now with the modified Hodge test, this is a fairly simple test that I think many of us are familiar with. With this test, you just lay down a lawn of a susceptible organism, place an ertapenem or imipenem disc in the center, and then streak your test organisms out from that disc. A strain that contains a carbapenemase, like KPC, will demonstrate an invagination of growth of the susceptible strain around the resistant strain, and that's demonstrated by strain A in this image. The other strains, while being carbapenem resistant, typically would have non-carbapenemase resistance mechanisms, again including efflux pumps, outer membrane porin mutations, or upregulation of AMP-C enzymes. This test is actually a relatively sensitive test for detection of KPC. However, when you look at detection of NDMs, there have been reports that the modified Hodge test is not nearly as sensitive for picking out the NDM enzymes. So what's the impact on hospitals? The impact of rapid diagnosis of bloodstream infections within a couple of hours of blood culture positivity. There have been a number of studies published, and all of them really show great benefit to rapid diagnostics. In the case of just separating something like Staph aureus, which of course is a true pathogen, versus coagulase-negative staph, which are a common contaminant in blood cultures, you can see in just differentiating between pathogen and non-pathogen, you can have a difference in hospital cost of up to $20,000 for all patients and up to $100,000 per patient in ICU. You also see an overall reduction in mortality of 53% overall and up to 80% reduction in ICU patients, and a 2-day reduction in length of stay for all patients and up to 7-day reduction of length of stay in the ICU. So these are huge institutional cost savings measures and also very, of course, beneficial to the patient. So because we're focusing on gram-negative organisms today, one of the technologies available is the gram-negative blood culture test, or BCGN. This test focuses on 9 gram-negative organisms, genus or species targets, as well as 6 associated resistance determinants. Now, there are certainly other microarray-based or multiplex panels that are going to give you more organisms. They may give you gram-positive organisms, gram-negative organisms, and yeast. And while those cast a wide net, which can be quite beneficial, and one of the advantages of these smaller or more syndromic panels is that they allow you to focus better on a smaller subset of organisms. So within that subset, in this case gram-negative organisms, you can have perhaps additional targets, increased specificity, and certainly more of the resistance determinants. This can also potentially contribute to keeping the cost of healthcare low by not testing for organisms that are not present. For example, if you see gram-negative organisms in a positive blood culture, there's no need to add on additional testing for gram-positive organisms. And as we move forward with a lot of these multiplex tests and complicated billing and reimbursement, really syndromic panels that are better focused towards what's actually present in the clinical specimen may be advantageous. So how does a test like this perform? This is data from the CE mark submission, and you can see that in this trial, 297 cultures positive blood cultures were included that contained gram-negative organisms. And for 7 of 9 of the targets on the panel, there was over 96% positive agreement with the gold standard method. And when you look at total agreement, which is positive plus negative agreement, you had over 99% agreement for each one of the targets. When you look at the resistance determinants, 5 of 6 had 100% positive and negative agreement with the gold standard method, which happened to be a combination of phenotypic as well as genotypic testing methods. On this list, really the 2 resistance determinants that stick out to me as being very important are the KPC and the NDM. With KPC, we're seeing more and more of these across the country, increasing prevalence, and so it's important to identify these rapidly as a marker, again, of multi-resistant organisms, but also from an infection control standpoint. We're lucky enough to be one of the clinical trial sites for the FDA submission, and during our clinical trial, we actually identified an NDM-positive E. coli. This is not only the first NDM identified at our institution, but also in our state. Because it was a clinical trial, of course, the specimen is de-identified, but had we been able to use this test for clinical care, this would have been very important in identifying this NDM, and especially from a infection control standpoint, because we would have known about this approximately 40 hours sooner than we did using our routine methods. Now, we hear a lot about MALDI-TOF these days, and we are certainly, as a lab, very interested in MALDI-TOF as well. This is a paper that focused on the utility of MALDI-TOF for identification of gram-negative organisms in positive blood cultures. Now, in this paper, I believe they subcultured these positive blood cultures prior to doing an identification using MALDI-TOF. There have been several reports out of our lab as well as others that have looked at direct identification from positive blood cultures using MALDI-TOF. And using these mechanisms, we can certainly turn out an identification in a very short time frame, maybe as little as 30 minutes. But with respect to gram-negative organisms, unless it's something like Acinetobacter that has a predictable resistance phenotype, there's not a lot of added utility that the clinician can really act on from an antimicrobial standpoint. Identifying Klebsiella or an E. coli doesn't really tell you anything about whether it carries a Carbapenemase or an ESBL. So using MALDI-TOF, while you can report out an identification rapidly, you still typically are going to need to wait to subculture that organism and do a susceptibility testing, which can take you up to 48 hours. So one of the real advantages of molecular tests is that you're able to turn out not only an identification, but the presence of resistance determinants in the same time frame, which in many cases is as little as 2 to 2.5 hours. Many of these molecular tests, again, are multiplex to include a number of the most common gram-negative or gram-positive pathogens that we run into in bloodstream infection, and results are available 24/7. These tests typically are quite simple, involving just a simple transfer of positive blood culture material to the test cartridge, with hands-on time of less than 5 minutes. Again, these results are available within 2.5 hours for providing clinically actionable results in a very short time frame. So with that, I'll turn it back over to Dr. Goff.
Thank you, Dr. Buchan. Okay, before I start, I just want to make sure, can you see my screen?
Yep, you're good to go, Dr. Goff.
Okay, thank you. So let's discuss outcomes. What is the goal of antimicrobial stewardship? It's really threefold. We're trying to decrease the emergence of resistance, improve patient clinical outcomes, and control cost. When we look at rapid diagnostic testing, how does that fit into the goal of stewardship? Well, anything that allows us to know sooner what organism the patient is growing allows us to get them on faster, appropriate therapy and hopefully improve our patient outcome. So we all know the standard method of testing without rapid diagnostic tests. We wait about 3 days for test results, and so that's 3 days a patient could possibly be on ineffective therapy. And with escalating resistance, that occurs many times. With rapid tests, once we have positive growth in the blood culture, we now very quickly can identify the organism, which allows us then to make interventions for appropriate therapy. So how do you actually make this work in your hospital? The key is you have to have an effective stewardship program with good communication between your micro lab and the stewardship team. Here at Ohio State, we really rely on Dr. Pincioli, who's our clinical microbiologist, to inform our stewardship team of any new rapid diagnostic test. And this is independent of cost. That's really our job as a stewardship team, to help cost justify some of these instruments by looking at the impact on patient care. So we rely on our microbiologists to present the different tests that are becoming available. They do an in-house validation, and that way we get experience with it. And then we discuss how this test would be used with our medical staff. Are the test reports going to be easy to interpret? The micro lab is limited to how the FDA actually puts the languaging in the package insert for the test, but sometimes that languaging is not intuitive to the end user. Does the physician need to be prompted to change their antimicrobial therapy? The answer to that is yes. So we really rely on our microlab not only to call the physician. A blood culture is considered a critical lab value, has to call the physician or nurse, but they also then add the stewardship pharmacist into that. And that's where we can then make a rapid assessment of the patient and call the physician with drug therapy optimization. So let's just look at some of the studies. We've reviewed a few of these already. This was our first one done by Dr. Bauer, published in CID, and was really our first example of how a rapid diagnostic blood culture test can make an impact on patient care. So this was using Cepheid's instrument at the time on MRSA Staph aureus blood, and we were able to show that we could reduce length of stay by 6.2 days in the group that we used the rapid diagnostic test with. But the most important thing, or one of the important things, was also the cost implications, a decrease of $21,000 per episode of Staph aureus bacteremia. I mean, that is pretty amazing when you look at driving decreased length of stay, specifically in the ICU, the impact that this one test had on patients here at our own institution. And this was with stewardship pharmacist interventions. So most of them were with MSSA, where we could rapidly switch from vancomycin to nafcillin, knowing vancomycin is inferior to nafcillin in the management of MSSA. In the management of MRSA, in the appropriate patients and those with high vancomycin MICs of 2, several were switched from vancomycin to daptomycin. So again, it's the right drug, the right dose at the right time can improve patient outcomes. Timing is everything, and a rapid diagnostic test affords us the ability to increase the time to effective therapy. We extended this the following year with Dr. Wong's study evaluating the impact of the rapid diagnostic test on coag-negative staph blood cultures, which we know generally in most patients will be a contaminant. But how many days do people continue on vancomycin until they realize it is a contaminant? And that was part of the goal of this study, which was a before-after study. You know, we were able to save 32 hours of discontinuation of antibiotics, 43.5 hours sooner to decrease antibiotic exposure. That is the goal of stewardship, getting them off antibiotic exposure when it's unnecessary. Infection-related length of stay was 4.5 days less, and infection-related and overall hospital costs were also decreased. So everything points in the right direction. We know with nanospheres, the Viragene blood culture gram-positive test, which also rapidly diagnoses and identifies the staph and strep species and enterococcus species, the time to effective reporting is decreased significantly by using this rapid diagnostic blood culture test. So integrating rapid diagnostic tests into stewardship, numerous studies now are showing increases in patient outcomes, decreased hospital costs. So we've already talked about Catherine Perez's paper with MALDI-TOF, which was really great looking at the impact of this new test. However, this is a very expensive test. The equipment, well, the test is not expensive, the equipment is expensive. So we do have this at Ohio State and are implementing its utilization and stewardship. When we look at her outcome results, they're quite impressive. We see shorter length of hospital stay and ICU length of stay, but keep in mind, as we've already just discussed, MALDI-TOF identifies the organism, but it doesn't tell me anything about resistance. So it's a little hard to change antibiotic therapy if you know it's Staph aureus, but you don't know if it's MRSA or MSSA. So there's some limitations to it. So when we look at Verigene's gram-negative test, here's a potential treatment algorithm I created, how I would utilize this as a stewardship pharmacist. We have piptazo, maybe with or without an aminoglycoside, depending on your own hospital susceptibilities, as empiric coverage for the gram-negative organisms of most concern and most frequent, Pseudomonas, E. coli, Klebsiella, Acinetobacter. So if I get back that it's a Pseudomonas, I'm probably going to continue my piptazo plus or minus my aminoglycoside. But now, with Verigene, I would know the resistance gene. How would that change? Would it change? And potentially, dependent upon your own susceptibilities in your hospital, the answer would be yes. If I look at my Klebsiella, which seems to be the most common, after I'd identify it, if I started with piptazo, I could de-escalate if I have a Kleb pneumo. It's either ceftriaxone or ertapenem. But what if I knew it was a KPC Kleb pneumo? Would that change my therapy? Well, yes. The appropriate therapy then is colistin. So I really need to know my patient population. One, from an epidemiology perspective, the patient's going in isolation. Do they have a history of a KPC? If yes, when I get this gene marker, it's going to trigger a switch because the odds of them having this KPC when the final culture is done is quite high. Have they been hospitalized abroad? Are they in my ICU? Are they a transplant patient, an immunocompromised patient? Are they from the nursing home, which is where we had our first outbreak? All of those are high-risk factors, and you can't afford to be wrong. Without a change, I'm sitting on wrong therapy for 3 days. For Acinetobacter, when I identify this rapidly now, colistin and minocycline is the most effective combination at Ohio State. So there's significant implications of how this test will empower us as stewardship pharmacists to make more rapid, effective change, and we know time is what is linked to patient outcome. So let me turn this back to Dr. Carroll to draw the conclusion to our webinar. Thank you.
Thank you very much, Dr. Goff. So before we conclude our session, I thought I would share with you the experience that we've had recently at Johns Hopkins. One of the questions that we asked ourselves as we embarked on rapid testing was, what value does rapid testing bring? In March of this year, we introduced the Verigene gram-positive assay for rapid identification of gram-positive organisms every shift, and we have noted the following success. We have reduced the time to identification for 91% of the gram-positive organisms that we recover from our blood culture bottles by 31 hours. And I can tell you that our antimicrobial stewardship group is very thrilled with that data. We've also realized a more rapid differentiation between pathogenic organisms and potential contaminants, and thus we are seeing an earlier discontinuation of unnecessary therapy for those contaminants. In addition, we have been DNA fish users now for quite some time, particularly the yeast assay, and we have been very successful in using this assay to predict susceptibility and thereby reduce overall echinocandin use, as has been reported by others. So what are the next steps? We hope to implement some sort of rapid identification of gram-negative pathogens and resistance markers in the next several months. And in addition to gathering data on the time to reduction of identification and costs saved with respect to discontinuation of unnecessary therapy, we'd like to dig deeper and actually assess patient outcome. We'd like to know if we're actually impacting patient morbidity and mortality. So in conclusion, we all know that healthcare is changing. Laboratories and healthcare institutions need to function at Medicare reimbursement levels. Accountable care organization type models will play a larger role in the future. And already we are seeing no reimbursement for some categories of healthcare associated infections and for early readmissions for some diagnoses. We know that rapid diagnostics are linked to reduced healthcare costs, and we've shown you some of that data in this webinar. This is through decreased length of stay as well as decreased pharmacy costs. And we've also seen an improvement in antimicrobial stewardship. And our antimicrobial stewardship team is quite busy now trying to use this data to impact patient care. The most important benefit, however, will be better patient care and better patient outcomes. And I think we still need more research to look at actual patient morbidity and mortality and how we might use these rapid diagnostics more effectively. At this point, I will now turn the webinar over to Rebecca, our moderator, for the question and answer period. Thank you very much.
Thank you so much, Dr. Carroll, as well as Dr. Goff and Dr. Buchanan. I'd like to thank you all for those very insightful presentations. So at this point, we'd like to open up a Q&A portion to follow up with this the webinar's presentations. I'd like to invite you all to continue sending your questions and comments right now using the questions window. I've already received some questions, so I'm going to go ahead and start with those. So our first question today is for Dr. Goff, and it reads, how did you get various constituents together at your hospital so everyone is vested in the value of the gram-positive test you implemented? So Dr. Goff, I'd be curious to hear your insights on that.
Sure. Well, it's the fundamentals of a stewardship program. It's a multidisciplinary program, so your microbiologists are instrumental in successful stewardship because they hold the key to all the organisms. You can't prescribe good antibiotics unless you know what organisms are in your hospital. So, getting everyone on board is getting the microbiologists to communicate the data to the stewardship team so we can then make an impact speaking directly to the physician and putting the orders and explaining to them the change in drug therapy that we might be recommending. Our medical staff absolutely embraces this because they really get guidance and an explanation why we might be switching antibiotic therapy. Instead of kind of the old way would be wait until the patient just doesn't respond very well and then they'd trigger an ID consult. And now we really move up that thought process by the stewardship pharmacist making an intervention. And in the management of bacteremic patients, we will always advocate an ID consult, especially in these multi-drug resistant organisms that are so complicated to manage. And so, it's easy to advocate for that as the pharmacist. And our physicians have really embraced it. And the key is we have the outcome data to prove it made a difference. Not only did it decrease length of stay and improve patient outcome, we also showed a cost benefit. So, it's everything that you want in a stewardship program, and we've published now several papers supporting what we do, and it just empowers the physicians to really get behind what the stewardship program's all about.
Great. Thank you so much, Dr. Goff, for really taking the time to walk us through that question. Unfortunately, it looks like we've reached the end of our webinar, and unfortunately we didn't get to pick the brains of Dr. Buchanan and Dr. Carroll. But with that said, our speakers have left us with an email address so that they can follow up with, they could possibly follow up with you and help hopefully answer some of the questions that you've posed for them today. So you'll be able to see this email address on your screen right now. It's webinar@nanosphere.us. With that said, I'd also like to thank our attendees for participating in today's conference. Today's audience can apply to receive a professional acknowledgement for continuing education or PRAISE credit issued by the American Society for Clinical Laboratory Science. Please pay attention to the exit surveys at the end of today's session to see if this is applicable to you. Again, I'd like to thank all our speakers today. That includes Dr. Carroll, Dr. Goff, and Dr. Buchan for an informative conference. And to everyone, I hope that you've had a great webinar and you'll have a great day.